We're going to perform a focal assessment on the abdomen today. Begin by obtaining your history, then progress to the physical exam. Wash your hands, don gloves, and check your patient's armband prior to doing your assessment. Students, you always want to make sure that you use some kind of antiseptic hand cleaner or wash your hands prior to get into the patient's room. Good morning, Mr. Lindley. How are you today?
Doing good.
I have a few students that are going to be in here, and you've agreed earlier to let me do your abdominal assessment and have them observe. Is that still okay with you?
That's fine.
Our plan is to kind of go over some questions with our history, and then we're going to go auscultate with the stethoscope on your abdomen, and then you're going to feel me feeling around on your abdomen, kind of poking around. You okay with all that?
Yes.
Okay. So how are you feeling?
Not feeling good at all. Feels like I pulled a muscle. Hurts my upper right quadrant up here on my stomach.
On a scale of 1 to 10, how bad would you say that pain is?
Right now about a 2, but it gets as high as about a 6.
Okay. Well, do you have any other medical problems with your stomach or abdomen, or had any surgeries or take any medicine for any problems related to your abdomen?
I just took some Malox once to, recently for pain. I mean, not for pain, just try to make it feel better.
Okay. Have you had any recent weight loss or gain?
I've lost about 50 pounds in about 6 months.
You trying to lose weight?
Yes, I'm on a self-determined diet.
Okay, or so you're exercising also with this weight loss.
Yes.
It's your intention to lose weight. Okay.
Yes.
Okay, so have you had any bloating in your abdomen at all?
Just a little bit.
Okay. And how frequently do you have bowel movements?
Every day, about once or twice a day.
Okay, how would you describe those bowel movements?
I would consider them normal, brown and soft.
Okay. So you haven't noticed any black tarry stools or liquid grape jelly-like substance?
No.
Nothing like that? And so you've recently been keeping that same bowel pattern, is that correct?
Yes, ma'am.
Okay. And so you said you took Malox for your stomach, but do you take any other prescription medicines for anything?
No, I do not.
Okay. Do you drink alcohol?
Rarely, like once or twice a year.
Okay. Do you smoke?
Never.
Do you do any kind of drugs like marijuana, cocaine?
Never.
So what kind of medical history does your family have?
My mom has bad reflux. My dad he had polyps when he had his colonoscopy. Not sure about my grandparents.
Well, students, I noticed that his mom has reflux, and he also said his dad had his colonoscopy and had polyps in there. So, part of health promotion is to make sure that the patient is continuing getting all their exams that they need on time. Another thing Mr. Lindley has done is he's lost a lot of weight recently, and that's really good, especially with our patient population here in Mississippi. A lot of things that patients have around here is non-alcoholic steatohepatitis, or what they commonly refer to as NASH. Okay, students, I'm going to be starting the physical part of the exam now. Mr. Lindley, so we're going to expose your abdomen. When you do this, students, you want to make sure you keep the privacy of the patient as much as possible. So you're actually going to look at the abdominal wall. You're looking for hernias, any kind of scars. You're also looking at the color of the abdomen for any kind of pallor or jaundice or just the normal appearance. You need to look how he responded when I was pulling the sheets down and stuff. See if he's guarded or he has any type of pain or he looks like he's trying to protect an area. You want to know a protuberant abdomen, a lot of times it's obesity, but it also can be a sign of ascites, so you just need to kind of look at that. You want to look for any masses or abnormalities there. You want to look for any kind of skin breaks. You see that Mr. Lindley has a very normal abdomen. He has some sparse hair that's on there. I don't see any physical scars. I see a few moles that are around. It seems to be flat, his abdomen is, and no signs of hernia, and I do not see a pulsation there where his aorta is. So you usually see a pulsation usually in really thin, young adults. So Mr. Lindley, what I'm going to do now is I'm going to measure your abdominal girth. Okay. Okay, so students, you'll want to slide the measuring tape under the patient's under the patient's back, and to measure the abdominal girth. You want to measure this at the area of the umbilicus, and you'll want to take your measurement into inches. So his abdominal girth is 38 inches. When you're assessing the abdomen, one thing that you really want to do is you want to use the 4 distinctive steps in how you do that. And you will want to do the inspection, the auscultation, then percussion, and then light and deep palpation, in that order. So Mr. Lindley, I'm going to start the auscultation part of your exam. That's to divide the abdomen into 4 quadrants. You have the right upper, the left lower, and the right lower. So you'll always work in a clockwise fashion when you're assessing the abdomen. So you want to listen to all 4 quadrants of the abdomen. So you'll do the right upper first. And you listen to about 5 to 10 seconds for normal pinging, gurgling, just normal bowel sounds. Now, if your patient's had an ileus, you won't really hear bowel sounds a lot, but you actually have to document absent bowel sounds. You have to listen 5 minutes in each quadrant before you can document that. So the next thing we're going to do is we're going to look at his aorta. So you'll also want to auscultate the aorta just a little over midline, right at the area of the umbilicus. And you're listening with the diaphragm of the stethoscope, and then you listen with the bell of the stethoscope. And what you're listening for is a turbulent noise, kind of a bruit is what it's called. It'll be a turbulent sound. It'll increase sometimes with their respirations, and you can hear it a little more. So then you want to auscultate over the renal arteries and the iliac arteries. And then basically you auscultate on down into the right femoral and then the left femoral. You'll want to take the bell of your stethoscope and you'll want to listen in the right upper quadrant. And what you're listening here is for a bruit with inspiration and expiration, and that's above the liver. And then you'll want to do the same thing on the left-hand side for the spleen and listen to see if you hear a bruit. We're going to start the percussion part of the exam. This is something that can require a lot of skill, so the more you do it, you'll actually get better at it. What you'll do is you'll take your non-dominant hand and you lay it on the patient's abdomen, and you essentially strike the distal joint of your middle finger with your dominant hand, middle finger. And it's a real quick, and you'll bump, bump, and lift up for that tympanic sound. So we're going to start in the right upper quadrant. And what we're doing is we're listening for that tympanic sound like a drum in all those areas. So we also need to percuss the liver border. So what you'll do is you'll start at the left area of the umbilicus, mid-clavicular line. You start at that point, and you're percussing up until you start to hear a dullness. And when you hear that dullness, you can put a mark, or you can mark it with your finger. And then you'll actually want to start around the 5th intercostal space at the top. You can't percuss over the ribs because you'll still have a dull sound. And then you percuss down until you see the top. And you'll want to mark that if the patient's in agreement. And then you'll take your tape measure and you measure. And it usually measures about 5 to 10. Now you can also percuss the spleen. It's definitely much harder to percuss, but it usually starts around the 5th intercostal space, and you would go up. But I'm at a strange angle here, but you would do the same thing, and you would come down, and then you can measure your splenic borders if you were on the left-hand side. To percuss over his kidneys, what you'll want to do is you'll want to do the costovertebral angle, which is right in the area of the kidney. And you will want to take your hand, ulnar side down, and you'll want to do a sharp thud back there. That's a sign of kidney inflammation. So with palpation, you just want to make sure you want to do light palpation, kind of around. You're feeling for any masses or abnormalities. Do deep palpation. You'll always want to start in the right iliac fossa, where the liver and the gallbladder area is. And so you'll put your hand here, and you'll tell the patient to take a deep breath. And as he inspires and exhales, you'll feel that lower edge of liver border. So, and then you just kind of feel around for that. Now, we're going to do a Murphy's sign test on Mr. Lindley. So, Mr. Lindley, I'm going to have you take a deep breath. And as you poke in, he's going to have that cessation of inspiration there. It's called an inspiratory arrest. Sorry about that, Mr. Lindley. So that's a Murphy sign, and that's actually a positive Murphy sign. Now we're going to palpate the spleen. So basically, you start over in the left iliac fossa, and you repeat the same thing that you did on the right side with the liver. So take a deep breath, Mr. Lindley. And with severe splenomegaly, you can actually feel, you can palpate that pretty good. Otherwise, it's not normal to palpate the spleen. Palpation of the left lower quadrant, and then you'll want to end up in the right lower quadrant, and you're again palpating for any masses or discomforts. You want to palpate for the appendix or appendicitis, so you do the anterior iliac superior crest, and then you have your umbilicus or your belly button, and you draw an imaginary line between the two, and about 2/3 of the way down, that's what we call the McBurney's point. And as you palpate this area, it will cause pain if they have an appendicitis. And a couple of special tests, basically, you're going to perform. Also, there's called the rebound test that you would test for appendicitis, and that's when you just kind of right at that McBurney's point, and you press down kind of hard, and then as you release, you'll see if they have pain worse with the rebound. That'll be rebound tenderness, and it is that's the name of the sign, and it usually is indicative of appendicitis. The Rossing sign, so basically what you would do on this side is you would find your anterior superior iliac crest, and you would have your umbilicus, and you would draw an imaginary line again between the two, and about 2/3 of the way through, you would want to press down and let go, and when you let go kind of rapidly, what that'll do is it would actually cause pain at the McBurney's point. Okay, your next test is called your iliopsoas test, and basically this is also for appendicitis, and you have the patient lift their right leg, and as you press down against the thigh, if that generates pain again here in the right lower quadrant, that would be a positive test. An additional test is called the arbitrator sign. So you'll have the patient flex at their right knee, and if you take your leg and you move it around, and if that creates pain in your right lower quadrant, that is another positive sign. So now you're going to palpate the aorta. So what you're going to do is right here above the umbilicus, you're actually going to press in. And what you're doing here is you're actually feeling for a pulse or an abnormality. Sometimes feel this with a AAA or abdominal aortic aneurysm. We're going to kind of review pain and what we've been over, and also address a couple of new points. If you divide the abdomen into 3 sections this way, you would have the epigastric area that would essentially be right under the xiphoid process. If the patient's complaining of pain in this area, usually associate that with an ulcer. Again, we're going to go over if they're having pain in the right upper quadrant and you have a Murphy sign, and it's a positive Murphy sign, that's usually linked to cholecystitis. You also could have an enlarged liver. You usually can't palpate the liver. You can feel the edge of the liver if the patient breathes in and out, but you usually can't palpate the liver unless there's hepatomegaly. On the left-hand side, you have the spleen. You usually cannot palpate the spleen. Again, in the right side, you have your appendicitis. That's your most common problem. Okay, so students, you can see obviously that Mr. Lindley has no ascites because his abdomen is not round and protuberant. On those patients, they will be kind of tough, hard, round and protuberant, and you want to do what they call the fluid wave test. So what you'll do is you'll have Mr. Lindley take his hand and put it like at the umbilicus, and you're going to have him hold that. And then you're going to come to the right side and the left side. And basically you're going to push that real quick, push it, and you're looking to see if the fluid wave actually travels over to the other side. Okay, Mr. Lindley, I do believe that concludes our exam for today. What I did notice that you had pain in the right upper quadrant area that got worse when you took a deep breath, and that the doctors actually scheduled you for an MRCP.